All right, we're going to go ahead and get started. Hello, everyone, and thank you for joining us tonight for our program. My name is Megan Schultz, and I am the Program Manager for the National Kidney Foundation of Eastern Missouri, Metro East, and Arkansas. Welcome to our professional education program, Adapting Kidney Care to the COVID-19 Pandemic, presented by fellows of Washington University School of Medicine, Dr. Jason Cummings and Dr. Mohamed Ibrahim, and fellows of St. Louis University School of Medicine, Dr. Mehdi Pahlavani, and Dr. Usama Elewa. Tonight's Renal Roundtable is in association with Dr. Tarek Alhamad, Dr. Stephen Cheng, and Dr. Rowena De Los Santos of Washington University School of Medicine, as well as Dr. Yazar Kaleskine, Dr. Lentine, Dr. Marie Philip Neri, and Dr. Maivo of St. Louis University School of Medicine. A special reminder to register for our upcoming Kidney Social Summit program on Sunday, February 6th at 2 p.m. This annual educational symposium is targeted toward kidney patients, their caregivers, and the general community who are looking to increase their knowledge of kidney health. I also encourage you to participate in our upcoming St. Louis Kidney Walk on Sunday, March 27th at 11 a.m. at Westport Plaza. Registration is open on our website. I just want to mention a few housekeeping items. If you have any questions throughout the program, please feel free to type them into the Q&A box that you will find at the bottom of your screen, and to clarify who the question is directed to based on the topic covered by the fellows this evening. Dr. Alhamad and Dr. Lentine, our moderators for this evening, will direct them to the presenters to answer them during our Q&A portion. You are also welcome to utilize the Zoom chat box. I want to thank our presenting sponsor, Alexion, for supporting this evening's program, and to our silver sponsors, Akebia, AstraZeneca, CareDx, Santa Fe Genzyme, and Veloxis, for allowing us to gather virtually this evening. We appreciate Amy Harper, Institute Account Manager, for her collaboration on behalf of Alexion. Thank you. I will now turn it over to you, Amy, to share a little bit more about the great work of Alexion.
Good evening, everyone. I am Amy Harper, the account manager for Alexion. We're a biopharmaceutical company that makes 5 transformative medications for 7 rare diseases and devastating conditions. 2 of these diseases, PNH and AHUS, both lead to kidney failure and can be fatal if left untreated. Our mission is to transform the lives of people affected by rare diseases and devastating conditions by continuously innovating and creating meaningful value in all that we do. We treat patients in over 50 countries around the world. I'd like to thank the physicians who are with us tonight.
So much, Megan and Amy, and we're really so delighted to have you all join us for this special Renal Roundtable. The past 2 years have been an unprecedented time in the field of medicine, and especially for nephrology. And this event was inspired by witnessing how our fellows adapted and learned during the stresses of the pandemic. And partnering with our colleagues at the National Kidney Foundation provides an ideal platform for sharing knowledge across institutions and with the broader community. And we hope that tonight marks the start of an annual event centered on community engagement around timely topics.
Very true, Dr. Lentine. The pandemic has put our renal community to the test. And I think we have grown stronger from it. #Stronger Together. Tonight, we have the 2 academic institutions of St. Louis get together to highlight some of the clinical and scholarship activities of our fellows during the pandemic, including work on AKI and biomarkers, COVID-19 hospitalization of kidney patients, kidney transplants, and managing the dialysis unit during COVID-19. I would like now to pass it to Dr. Cheng and Dr. Vo, who will share a few highlights of our training programs.
Hi, everyone. I'm Stephen Cheng. I'm one of the program directors at Washington University. We're incredibly fortunate to have several really great training programs here in the St. Louis area, all of which offer world-class training. And this has really allowed us to bring in some of these exceptionally talented young physicians to join our community here in St. Louis and be able to train them in a variety of new and exciting new pathways in nephrology. Dr. Vo and I are really honored to be able to work with these young physicians. And we're also very proud of our training programs and the outstanding attributes of those programs.
Hi, I'm Mai Vo from SLU. Here at SLU, under the leadership of Dr. Kevin Martin, we've been able to expand our fellowship to train fellows, not only in general nephrology, but also give them a unique experience and train them in intervention nephrology.
And over at WashU, with the leadership of our division chair, Dr. Ben Humphreys, we're training our fellows for careers in general nephrology, transplant, critical care, and even medical education.
But tonight, it's all about our trainees. All of our fellows have shown amazing resilience during these really difficult times, as we all know. And some of them have actually even incorporated these challenges into their scholarly work. So tonight, we'd like to showcase them and give them a chance to share their work during the COVID pandemic. So Dr. Cheng and I are very excited to introduce you to a few of these fellows tonight.
And first up, we are going to hear from Dr. Jason Cummings. Jason received his Bachelor of Science from the University of Florida in Gainesville. He then did med school at St. George's, and then he did residency at Florida Atlantic, where he also served as a chief resident. He came to us for fellowship. Of note, Jason is a scuba diver, a weightlifter, and a future critical care nephrologist. Jason is going to tell us about his interest and his project in assessing biomarkers related to AKI in COVID.
Thank you for that introduction, Dr. Cheng, and thanks to the NKF for this opportunity. I'm excited to speak a little bit on our project that's looking at biomarker assessment of acute kidney injury in patients with SARS-CoV-2 infection. I have no disclosures. To begin, we'll underscore the significance of renal involvement in patients with COVID-19 pneumonia. In this retrospective single center study of Chinese patients with COVID-19 pneumonia, 251 of 333 patients, which is almost 76%, presented with renal complications, including proteinuria, hematuria, and acute kidney injury. Additionally, patients with renal involvement had higher overall mortality at 11.2% compared to patients without renal involvement, which were at 1.2%. In a September 2020 paper authored by Washington University nephrologists Dr. Vijayan and Dr. Humphreys, these potential mechanisms of AKI and COVID-19 were discussed. SARS-CoV-2 may transduce podocytes, possibly leading to collapsing glomerulopathy. Alternatively, tubular epithelial transduction could lead to tubular injury and AKI. SARS-CoV-2 infection of lung parenchyma leads to systemic inflammation and microvascular thrombosis, contributing to hemodynamic instability, as well as peri-intubation hypotension may worsen kidney perfusion, leading to ischemic tubular injury. Our current method of diagnosing clinical AKI rely on the rise of serum creatinine, which, as we all know, severely limits timely detection of AKI or its underlying etiology. Serum creatinine is not sensitive or specific in detecting early or subclinical AKI. Serum creatinine is a byproduct of muscle metabolism and can change due to various factors, including body mass, diet, and other hospital interventions independent of the kidney injury. Serum creatinine also does not delineate the etiology of kidney dysfunction nor predict its progression to CKD. If we compare this to an ideal biomarker for acute kidney injury, which would help clinicians and scientists diagnose acute kidney injury early and accurately, and may aid to risk stratify patients with acute kidney injury by predicting need for renal replacement therapy, the duration of the acute kidney injury, the length of stay, and mortality. Back to AKI and COVID-19. COVID-19 patients may present with subclinical AKI that, if identified early, may predict the kidney injury course and change clinical management to minimize morbidity and mortality. As discussed, the renal response to COVID-19 at a cellular level, at cellular molecular level, remains undefined, therefore limiting approaches to design targeted therapies or better diagnostic markers. This leads to the first aim of our study, which is to detect AKI and identify its putative region or cell source before functional decline in COVID-19 positive patients using high throughput multiplexed analyte assays. We hope to determine the kidney injury marker phenotype in COVID-19 patients. identify which markers define COVID-19 AKI, determine if these markers will help us identify subclinical acute kidney injury, and which markers are associated with worse prognosis, and potentially even identify therapeutic targets. The major types of urinary biomarkers fall into three classes: inflammatory, renal tubular proteins that are excreted from the urine after injury, and surrogate markers of tubular injury. For example, IL-9 and TNF-alpha in urine are upregulated in acute interstitial nephritis compared to other causes of AKI and are indicative of a CD4 T helper cell response. Markers that are bold underlined in this figure will be examined by our study. So we intend to enroll patients, process and preserve urines, collect clinical data, identify COVID-19 positive patients with severe AKI and no AKI, further identify biomarkers which will be tested, run our assays, analyze the data. And currently we're at this step here where we're identifying our COVID-19 positive patients with severe AKI and no AKI. Fresh urine samples were seriously collected from COVID-19 patients between March and September of 2020. All clinical metadata are available in a de-identified manner, including demographics, comorbidities, medications, clinical labs, time and sample of collection from onset of symptoms and processing. We're focusing on samples collected within 7 days of symptom onset to increase the likelihood of detecting early AKI and where serum creatinine is typically normal, and using a mesoscale discovery multiplex panels of biomarkers and an in-house immunoassay for MIOX, which is incidental oxygenase, a highly specific novel marker to detect proximal tubular injury. So where are we now? Here is a snapshot of patient characteristics which have been collected, including variations of COVID-19 positivity and severity, as well as kidney injury presence and severity. From here, we will match controls, finalize our list of biomarkers to test, run the assays, and lastly, analyze our data. This pilot study of urine proteomics and COVID-19 associated acute kidney injury out of Washington University's Kidneys Translational Research Center, the same lab which is conducting the study I'm speaking on tonight, analyzed urine samples from 14 participants, 16 with COVID and acute kidney injury, 3 with COVID and no acute kidney injury, and 5 with no COVID-19 infection and no acute kidney injury. This study identified the complement and coagulation cascade pathways and exocytosis pathway were highly upregulated in patients with COVID AKI and provided us with a proof of concept. I would like to thank you all once again for allowing me the opportunity to speak and for listening.
Wonderful. Well, thank you so much for that excellent talk, Dr. Cummings. And again, folks, will be saving all Q&A for the end and hope to have a robust discussion at the end of the presentations. So it's now my great pleasure to introduce our next speaker, Dr. Mehdi Pahlavani. Mehdi came to our program after training in internal medicine at Tehran University and serving as an attending physician in Iran. He participated in cardiology research at Beth Israel Deaconess and has published more than 50 articles and chapters to date. And the idea for this project arose at the start of the pandemic when Dr. Keliskan, Mehdi, and I recognized that it would be worthwhile to track the experience of kidney patients with COVID-19 receiving inpatient care on our acute and transplant services. So Mehdi jumped right in and took the lead in programming the data collection instrument and helping organize this effort with collaboration across our division. I do want to give special thanks to PA Ariel Schnell, who has been a wonderful partner in her daily coordination with our inpatient services, and of course to all our nurses and care partners who contributed to the care of these patients. So thank you, Mehdi, for sharing this experience.
Thank you very much, Dr. Lentine, for the introduction, and good evening, everyone. I was honored to be able to serve our kidney patients during the pandemic, and at the same time work on this project with Dr. Lentine and Dr. Kaliskan and the rest of our nephrology department. Talking about our project, COVID-19 pandemic has affected almost 46 million people with more than 750,000 deaths in the United States today. The first confirmed patient in Missouri was reported on March 9, 2020. And since then, more than 880,000 confirmed cases with 13,000 reported deaths was reported in the Missouri. We performed this study to better understand COVID-19 pattern in patients with various stages of kidney disease in our patient population at the SLU hospital who were admitted to our facility. The study design was a retrospective cohort study, and 171 confirmed COVID-19 patients who were admitted to SLU hospital from March 2020 till July 2021 were enrolled in this study. And the predictor for this study was having either AKI, being on dialysis as a CKD stage 5, or having a kidney transplant. Our primary outcome was in hospital death, and the secondary outcome was need for mechanical ventilation, plus minus circulatory support or renal resupplement therapy requirements. We performed frequency analysis and chi-square tests to evaluate and compare the patient characteristics between the groups. Talking about the basic characteristic of our patient population that were enrolled in the study, we had 89 patients in the AKI group, 54 patients in the dialysis group, and 28 patients in transplant. The mean age between these groups was ranged from 56 to 65. Female ratio was 37% in AKI group and about 45% in CKD and transplant. 52% of our patient population in AKI group were African American, and it was significantly higher in our dialysis and transplant group with 82% and 68%. The most common comorbidities among our patient population were hypertension and diabetes, which was almost around 90% of our cases had the hypertension. And interestingly, only about 20% of our patients had underlying lung disease. I'm glad to express that none of our transplant patients were currently a smoker, and almost 47% of our patients were never smoked in those AKI group and dialysis group. Fever, shortness of breath, and cough were the most common presenting features. The patient in AKI group had the longest duration in hospital stay with the mean 20 days, which was significantly higher than the other two groups, which was around 12 days. 73% of our patients in the AKI group were admitted to the ICU, which was significantly higher than the other two groups. Almost 54% of our patients in AKI group required intubation and mechanical ventilation, which was almost 2 times of the other two groups, which are around 20%. 8% in AKI group underwent ECMO. Vasopressors were required in almost 60% of our AKI group and 22% of our transplant or dialysis patients. Talking about the treatment of COVID-19, dexamethasone was the most common medicine that we used, and it was followed by azithromycin, which was in the beginning of the pandemic. Sorry.
Can you back it up, Megan, for Mehdi?
I cannot go back. I'm sorry.
You can just discuss it, Mehdi.
Okay, sure. about renal replacement therapy requirement. Thank you. 20% of our AKI group underwent intermittent hemodialysis, and it was almost 48% of our AKI group that didn't require renal replacement therapy, and 82% of our transplant patients also didn't require renal replacement therapy. About the mortality, AKI group had the highest mortality with 50%, CKD stage 5 and transplantation has around 24% of mortality. And the most common etiology for death among this patient group was ARDS. But talking about the outcomes of our study, we can compare side by side about our different patient group. That death was most common in the AKI group with around 50%. Almost 52% of our AKI group required renal replacement therapy. CRRT was done in around 35% of AKI group. Vasopressor was required around 60%, and intubation and ventilation was done in 54% of our AKI group. Here is a kind of recap for our cohort study in AKI patients. As an infographic, 89% of AKI with a mean age of 65. Female had 37%, and 52% were African American. 73% of them were admitted to the ICU, and 54% required intubation. 8% underwent ECMO, which was 9% of our patient population in AKI group. 52% of our AKI group required renal replacement therapy, and 51% mortality was observed in this group. In dialysis patient, we had 54 patients. The mean age was 62, with 44% of female. 81% were African American, and 48% had a history of smoking. Only 28% were admitted to the ICU. 43% were required nasal cannula for oxygen supplementation, and 22% had intubation and mechanical ventilation. This intermittent hemodialysis were done in 85%, and 17% underwent CRRT. And we had 24% mortality in this group. Transplant patient, the mean age was 58, female was 46%, and African American patients were 68%. 32% of this group were admitted to the ICU, and 25% were intubated. And around 11% had CRRT, and the other 11% had intermittent hemodialysis with 18% mortality. To compare the case and death rate per month, we had a peak in the beginning of the pandemic in April last year, and after that it was plateaued. Then again in September, we had another peak that was picked up to around 30% in a month, with 10 patient death in December. And then it went down and was plateaued till July that the study was concluded. Concluding about what we talked about, we observed higher mortality and renal replacement therapy need among hospitalized COVID-19 patients, especially in AKI group, that we use this information for consulting our patients for preventive measures, especially overcoming vaccine hesitation. And we would say that in the current and future pandemic, public health and therapeutic studies, we would focus on the mitigating disease transmission and optimizing outcomes in this vulnerable population. And my colleague, Dr. Elewa, will talk about them in a minute about our strategies in chronic dialysis units. Being said, I want to say thank you and appreciate our frontline workers, practitioners, and for their dedication in patient care, including nurses, technicians, and physician colleagues. I want to especially thank your nephrology division faculty for their support. Being said that, I want to transfer this talk to Dr. De Los Santos as our next speaker.
Hello, our next speaker is Dr. Mohamed Ibrahim. Dr. Ibrahim completed his medical education and residency in Egypt, followed by a research fellowship at Duke, where he published over 30 articles. He completed his nephrology fellowship at the University of Buffalo, and he is currently a transplant nephrology fellow here at Washington University. His talk is titled, kidney transplant in the era of COVID-19.
Thank you very much, Dr. De Los Santos, for the introduction. So transplant volumes have decreased significantly during the first month of the pandemic. That was followed by a shift in the standard of care of transplant medicine overall. It has become widely accepted to screen donors and recipients for COVID-19 before proceeding with the transplant. For the recipients, the protocols required each recipient to have a negative COVID-19 PCR prior to proceeding with the transplantation. Many transplants were delayed nationwide due to persistent positivity of PCRs in even asymptomatic patients, sometimes for months. For the deceased donors, we have rejected many kidneys that were discarded due to positive COVID-19 PCRs. This has possessed a new challenge for all the transplant centers nationwide. For the living donors, a positive COVID-19 testing can delay the procedure and even sometimes potentially disqualify the donor. Recently, there is an emerging vaccines and lines of therapies that have given us more tools that could be utilized to rebalance the shift in the practice and maximize the organ utilization. And to give you an idea, panel A here shows the COVID-19 hospitalization rates in the year of 2020. You can see that COVID-19 hospitalization had a first peak in April with about 130,000 hospitalization overall. This was followed by even larger peak of hospitalization reaching up to 170,000 hospitalization by December. Panel B here shows the correspondence in the number of donors recovered from kidney transplant and the number of deceased donors and living donors as well. You can see that the numbers of deceased and living donors has decreased in a ratio that corresponds to the increase in the hospitalization rate. And that has limited the number of transplants overall nationwide. So usually desperate times call for desperate measures. However, in our transplant world, everything has to be measured. Everything has to be calculated in order to have more efficient outcomes. So I'm going to speak briefly today about the challenges and the decisions we had to make in our transplant centers. First, our previous protocols and prior protocols overall required to have a negative COVID-19 PCR prior to proceeding with transplantation in the recipients. So positive recipients were not really allowed to undergo transplantation until they become negative. For the COVID-19 positive donors, prior protocols would disqualify most donors just because of the positivity, even if there are no symptoms. So I'm going to present you with case one, which is a COVID-19 positive recipient. Briefly, this is a 64-year-old Caucasian female with stage 5 chronic kidney disease, secondary to Alport syndrome. She worked at a nursing home and she tested positive for COVID-19 by a rapid antigen test. She never developed any respiratory symptoms, and her fever has subsided only after 1 day without any specific therapy. 6 weeks later, she was called for a deceased donor kidney transplant organ offer. We admitted her, and upon admission, we did a nasopharyngeal specimen, and we ran a COVID-19 PCR, which was positive. The cycle threshold values, which we used for the test, and this is basically the number of the cycles that are needed to detect a certain viral load. The cycle threshold values for COVID-19 assay for this patient was about 35 and 30.3 respectively. Our lab cutoff of 30 indicates low viral load. So the higher the CT values, the lower the viral load. At that time, the patient was asymptomatic for about 6 weeks. She had a negative chest X-ray And as I mentioned, she had a high cycle threshold on PCR. So we thought at this time that this positive test was basically a detection of residual COVID-19 RNA particles in the absence of active infectious viral particles. So a question for you, like our current protocols at this time, it actually has disallowed us from accepting such a donor. So the question is, and feel free to comment in the question and answer section, would you proceed with this transplant or not? Most centers would say no, and that included our center at that time. However, we decided to proceed with the kidney transplant per our regular induction and immune suppression induction and maintenance protocols. And our justification for this, as I mentioned, it was just the low viral particles and the fact that she was asymptomatic with no pulmonary symptoms or systematic symptoms. The patient remained asymptomatic without any fever or signs of infection up to 4 months of follow-up from the time of transplantation. She did not develop any COVID-19 infection. And we reported this in AGT, and this was the first reported case of past history of COVID-19 and detectable COVID-19 RNA by PCR at the time of transplantation. The next two cases are cases from a COVID-19 positive donor. The first person was, or the first patient was a 40-year-old female who has been vaccinated with 2 doses of mRNA vaccine 5 months before transplantation. The second patient was a 41-year-old male without a prior COVID-19 vaccine. However, he had a natural infection with COVID-19 10 months prior to the transplant. And at that time, his IgG antibody was positive. Both patients, the male and the female, had negative COVID-19 nasopharyngeal swab PCRs prior to transplantation. The donor, 2 kidneys from the same donor who tested positive by PCR for COVID-19 from a nasopharyngeal swab 3 days prior to procurement. On the following day, which is 2 days prior to procurement, the donor bronchial washing was negative for COVID-19. At the day of the procurement, repeat PCR was done from the nasopharyngeal swab, and it was COVID-19 negative. However, the antibody was positive. The cause of death for this donor was a head trauma. The terminal creatinine was 0.3 milligram per deciliter. And the chest imaging at that time showed no COVID-19 lung effects. So the same question again, would you proceed with transplant in such patient? Most protocols at this time require to have a longer period of COVID-19 negativity before proceeding with the transplant. However, we decided to go ahead and we proceeded with the kidney transplant per our regular standard protocols of immune suppression, induction, and maintenance. Both recipients had an appropriate renal allograft function. The novel thing we have done is that we have provided post-exposure prophylaxis with casirivimab and MDVimab, which is called Regenkov, and we gave this 24 hours after the last dose of thymoglobin. Up to 10 weeks after transplant, both recipients had no symptoms of COVID-19 infection, and they remain asymptomatic so far. So to conclude, COVID-19 pandemic has significantly decreased the transplant volume and altered the transplant protocols nationwide. The kidney transplantation may be safely carried out in asymptomatic patients, recipients with a persistently positive COVID-19 PCR, as we have demonstrated. We can broaden the scope of accepting organs from COVID-19 positive deceased donors with no renal involvement. The new emerging vaccines and lines of therapies and antibodies have given us more tools that we can utilize to rebalance the shift and maximize our numbers again. And we also introduced the use of casirivimab and mdivimab for immediate post-transplant surgery prophylaxis. I would like to thank the National Kidney Foundation for this opportunity, and I would like to thank all the transplant team, my medical director, my program director at WashU. And please, if you have any questions, just write them in the Q&A section below. Thank you.
It's my pleasure to introduce to you our fellow, Dr. Usama Elewa, who completed his medical education, internal medicine residency, as well as nephrology fellowship at the world-renowned Ain Shams University in Cairo, Egypt. He then went on to go to the Mayo Clinic as a visiting professor, where he worked with the world-renowned Dr. Fernando Fervenza. After that, he went on to get a PhD at the University Hospital of Madrid, where he completed his research fellowship. He then worked in Egypt and Saudi Arabia as an attending physician in nephrology, after which we were very delighted to accept him into our fellowship program, and he's been with us for the last several years.
Thank you, Dr. Vo, for this kind introduction. Today, I will talk about managing dialysis unit during the COVID-19 pandemic. The outline of my talk will be our single center experience with the newly implemented infection control measures, multidisciplinary approach in response to COVID, and our external collaboration. And what are the lessons learned from the pandemic, and what would be our future directions? FMC St. Louis Grant, located in St. Louis University Medical Campus and supported by SLU Care nephrology providers, host an average 125 in-center hemodialysis and 25 home dialysis patients. From January 2020 till now, the positivity rate of COVID-19 among our dialysis patients was about 14%, with higher rate among home dialysis patients, and half of the patients required hospitalization. And our quarter evaluation showed lower infection rate in 2021 following vaccination, with no identifiable outbreaks in the facility. In comparison to different studies worldwide, positivity rate looks relatively higher in our facility. That is mostly attributed to larger follow-up duration over 20 months instead of 4 months in most of the studies. On the other hand, we had lower death rate of 11.1%. That can be due to small number of patients. We responded early prior to identification of the first COVID-19 confirmed case in the city. We had QI meeting in February 27, discussed the new infection control measures that were applied next day on the 28th by providing the educational material to patient and staff, starting patient and staff screening, face covering, and social distancing, and providing isolation room for evaluation of symptomatic patients. Telehealth visit of home dialysis started on March 15, and on 16th, which initiated communication with nephrologists in St. Louis area. And on the 22nd, we activated the isolation clinics and shifts, which I will discuss in a minute. And we sent letters to nursing homes with our new infection control measures, in addition to regular scheduled QI meetings to discuss further measures in response to the pandemic updates. The newly implemented infection control measures included updated facility procedures, patient screening, measures for healthcare providers, dialysis facility isolation, and nursing home facilities measures. We applied new procedures like visitors were no longer permitted. Eating during dialysis has been firmly eliminated. Private waiting room were used for home dialysis, and waiting room seats in the clinic and at transportation were spaced out by 6 feet. And nearly 1/2 of the monthly in-center hemodialysis visits and all home therapy visits were performed virtually. And these procedures were, in addition to universal measures as good hygiene, disinfection of workplace frequently and in between users, face covering using medical masks for patient and staff through their time in the facility. Regarding patient screening, official screening temperature threshold was set at 100.4, and every patient was screened for respiratory symptoms and fever upon arrival to the clinic. Nursing staff consulted with providers for any low-grade fever. Over 99 were found with suspicious symptoms. For healthcare providers, the risk of carrying the virus from the inpatient setting to the outpatient dialysis was an early identified hazard. So we split our provider into two teams. Team A taking care of the inpatient, and Team B for the outpatient dialysis. In terms of isolation practices, the isolation shifts were divided among 3 dialysis units in the area. Hampton was designated for the confirmed cases, Chateau was designated for the close contact, and our unit was designated as a site of BOI isolation. And each unit scheduled their isolation patient on the 3rd shift. And the 3 unit managers used to have a daily video conference to share information regarding their patients. We were concerned about the reports of COVID-19 outbreaks within nursing homes across the country. So all nursing homes caring for our patients were informed of the unit's infection control measure and the screening expectations. And we have continued regular communication with them to remain aware of any outbreaks. Patients residing in a nursing home with any confirmed COVID-19 case were dialyzed on the close contact isolation facility. 18.5% of COVID positive cases were from nursing home, whereas only 6.3% of our dialysis patients are from nursing home. We applied multidisciplinary approach to COVID as we realized from the very beginning that we are all responsible and everyone has a role. The patient to wear a mask at the dialysis facility, to maintain social distance, and families not to accompany patient to dialysis. Dialysis staff to follow the infection control measures, stay home and get tested if symptomatic, and to report positive test results or any close contact exposure. Providers to educate patient and staff about the COVID, provide in-person or virtual visits as appropriate. Leadership to review and implement infection-related policies, monitor compliance, ensure personnel are trained, and address any safety concern. Administration to provide updates regarding the COVID infection, communicate frequent revisions to the infection control measures, ensure availability of adequate resources at the dialysis facility. And remember, cleaning and organizing is a practice, is not a project. Creating multiple lines of communication during the pandemic are very important. The extensive communication and team-based approach early on with local health departments, other dialysis clinics, area hospitals, nursing home, CMS, CDC, and professional organization as ASN and NKF has made a meaningful impact on containing the spread through our dialysis patients and avoid outbreaks. Vaccination was started in March 21 for our patients using Moderna with a vaccination rate to date of 69%. And we had 5 COVID positive cases during the post-vaccination period, and vaccination of staff went into full effect in January 21, using Pfizer with vaccination rate to date of 88%. We got good experience and a lot of lessons learned from the current COVID pandemic, like identification of potential contamination sources and apply appropriate measures like splitting healthcare providers, isolation measures, and separate transportation for confirmed cases, to incorporate infection control measures into workflows and ensure being effectively implemented, to establish a multidisciplinary approach and ensure bidirectional flow of information between staff and patient. Extensive communication early on and engaging with CDC, local health departments, and professional organizations are very important and provide information that help creating better management strategies. Patient engagement and education are critical for the success of infection control during the pandemic. But we still have some challenges that need answers and should be addressed, like patient transportation that can be a source of cross-contamination, need of rapid test and contact tracing process. What about immunity status post-infection and post-vaccination? And are we ready to apply outpatient treatment like monoclonal antibody in our dialysis facilities? And being understaffed, which is still a universal concern, and would like to learn from your experience and welcome any comments. And finally, I would like to thank our colleagues in St. Louis University Division of Nephrology and FMC St. Louis dialysis staff, NKF for this opportunity. Thank you all and have a good evening.
All right, well, if we can have the full panel come up, and we've received a number of great questions either in the Q&A box or in the chat. So we'll just kick off this discussion. So Dr. Cummings, we have a question from one of our fellows, Dr. Mohamed, and going back to your biomarker presentation, she would like to know how the biomarker levels were related to outcomes and if they affected the WHO severity scoring for COVID.
Sure, great question. Thank you for the question. And that's essentially precisely what we're going after with this study, is to identify a biomarker or biomarkers that correlate and hopefully relate to causation of the mechanism of COVID AKI that are prognostic and a possible therapeutic target. So we're in the thick of it right now, and we'll hopefully be running these numerous assays soon. So to your question, I say hopefully check back soon. And with regard to the second portion about the WHO severity scoring of COVID, so it looks like the majority of the scoring system is centered around pulmonary symptoms and oxygen requirements, intubation, with dialysis being there towards the end. I think, of course, I'm biased that I think AKI should definitely be inserted into severity indexes with regard to COVID-19 pneumonia. You know, it's clear that patients with COVID-19 and AKI do worse than those without.
Excellent, Dr. Alhamad.
Yeah, I have a couple of questions here for Dr. Ibrahim. So would you, now the question, is vaccination mandatory to kidney transplant? And would you make it mandatory if you get the chance? And if you want to do that, what do you think?
So right now it's center specific. Some centers require mandatory vaccination, and even if the patient gets cleared for transplant, they would not transplant the patient unless they are fully vaccinated. Our center now at WashU, it's not a requirement, it's a recommendation, but it's not a requirement. And actually, which is very interesting, we get people who come to try to enlist in our center just because they would not get vaccinated in the other centers that already cleared them. If it's my preference, I still highly recommend it. I would not make it a mandatory recommendation at this point, just because we still have like all these strains that come out, and then we have all the kind of new booster shots that will come out. So probably it's not fair, you know, and to ask the patients if they don't want to. We still have like highly recommended, but I probably personally would not make it a mandatory recommendation. But of course, if my center agrees to make it mandatory, then we'll go with the center.
I just wanted to expand a little bit on that, the discussion. Thanks, Dr. Ibrahim. That was a great response, and just highlight that it's a really controversial topic in the field right now. And with Dr. Kaliska and also Dr. Alhamad, we've been doing a couple surveys of transplant programs kind of across the pandemic, including one that we have going now, both for the US and international. And it really balances all the considerations that you're speaking about, including the data that the efficacy is likely higher on the wait list versus post-transplant when the patient is on immunosuppression, the morbidity and mortality data, as Mehdi highlighted, versus concerns about disparities in access to transplant. So just wanted to expand on that work. Thank you.
Sure. Dr. Weir actually is online, and he's asking you a tough question. any data on the percentage of transplant programs accepting organs from COVID positive patients? So as you know, Mo, that the discard of kidneys from donors with COVID-19 has been high. So the question is, how many centers have been now accept COVID-19 positive patients? I think you are referring to accepting donors with COVID-19 positive.
So I think, I'm not sure if we still have enough data to give exact percentage as of yet, because I know some centers are now starting to open up. And actually, speaking of Dr. Ware, I know that University of Maryland probably now starting to accept a COVID-19 test that has been negative for at least 2 weeks prior to transplantation. The two cases that I presented here, basically it has been negative only for 2 days. And again, like, I don't think we have enough data yet to draw like percentages, but I think right now, as actually Ohio State as well have just published a series of 10 cases of donor positive, of COVID positive donors at certain stages, at multiple stages. And I think they have good results. So I think the more centers start to publish some of these cases and actually transplant, this will encourage other centers to do it. And hopefully at some point we'll be able to have a 100% percentage of centers accepting positive donors.
That's great. Well, your presentation was very popular. We've got actually an array of questions on transplantation, including for the cases in which you used an organ from a positive donor. Could you expand a little bit about the post-transplant monitoring for these patients?
So what we tried to do, which I think it was a very wise move from our center, is that actually we tried to keep everything as standard protocol. We did not do any special change in immune suppression, either induction or maintenance. We basically did everything as the protocol. We did not even add like extra COVID-19 testing prior to that. So as long as they have not developed any symptoms, we even followed the protocol for that. So if any of these patients would have like to develop like symptoms that we think they are COVID-19 symptoms, we probably would just treat them as other patients and we just swab them. That's like how we do with all our patients. So everything was done per protocol. We did not give them more or less immune suppression, either induction or maintenance. And the very interesting thing about the two cases is one of them was vaccinated and the other was not vaccinated. So we had both spectrum.
I wanted to tie, thank you so much for that excellent response. It tie back to the vaccine hesitancy discussion, which applies not only to transplantation, but can apply to our dialysis, to our CKD and general patients. And just wanted some insights, Dr. Elewa, Dr. Pahlavani, Dr. Cummings, about the discussions that you're having with your patients kind of across areas of nephrology. How about you, Usama, in the dialysis unit with regarding vaccination discussions and kind of using this evidence to inform and overcome hesitancy?
Yeah, we had only 69% of our patients, like to date, got vaccination, and even the staff is still like 88%. So we're still having some conversation and convince patients with vaccination, especially with the new variants right now and the risks that we have.
Any other comments on that one?
I would like to add that.
Yeah, thank you.
Can you hear me?
Yes, ma'am.
Great. Marie Philip Neri. The national average for vaccination among dialysis patients is about 80%, and we are trailing a bit behind. It's been an effort. Again, a multidisciplinary effort. All of us try and present the data, and it's going to be an ongoing challenge, especially in our population in the city.
Okay, I had a question that I wanted to direct to our colleague, Dr. Kalaskan, regarding both.
Presentation and great study. First, I want to say that. And the other thing that just came to my mind, you have different groups. You have COVID with AKI, you have COVID without AKI. I think in the COVID, one of the important things is to differentiate the kidney problem from the sepsis-associated kidney disease, AKI. So maybe if you have another control group with non-COVID sepsis or high inflammation status and AKI, your biomarkers can help us what is happening exactly in the kidney in COVID, different from all other infections and sepsis.
Right, you bring up an extremely valid point that it's multi-layered, multifaceted, and if there is overlap with other disease process, and if there's this kind of unique phenotype of COVID AKI, proteomics would be wonderful to find. Like I alluded to, that pilot study out of the same lab is showing some complement activation pathways and things along those lines. So hopefully something tangible will come up, but it's going to take. We're fortunate. There were some very forward-thinking people at Washington University when this started, and collecting urines and serially that are in a freezer downstairs, along with a ton of demographic information and clinical information and markers, biomarkers, otherwise throughout the course of the hospitalization. So hopefully we'll be able to take the wheat from the shaft here and find something that we can all benefit from.
Thank you. Great.
Dr. Pahlavani, your presentation really highlighted the high morbidity and mortality faced by our kidney patients who also had COVID-19. And I wonder, just kind of going beyond the data, if you could describe a little bit what it was like to work on the medicine floors, on the nephrology floors during the pandemic. What do you sort of take away from that as a physician going through that experience?
Sure. So what we observed, as you said, as we discussed, was the higher mortality in this group of patients. So having this mindset that AKI in the COVID patient may predict poor outcome. So prompt treatment, being some more motivated about treating some other underlying condition, like being more proactive regarding if patient has any kind of like hypotension or other risk factor that may predispose them to progressing AKI. Be more proactive on that part could be some lesson that we learned from this study. And also, as we discussed, being more proactive regarding patient education, regarding vaccination and preventive measures is another point that we learned from this study. As in our daily practice, we can discuss with our patient and encourage them to be aware of this high risk if they get the infection.
Thank you for sharing that. Dr. Alhamad, do you see any more questions, or have we answered most of them?
I think we answered most of them, and I think our time is up here.
Okay.
I would like to make just one comment that as a nephrologist, I've seen post-COVID or long COVID syndrome among patients. For instance, I had a PD patient who tested positive before initiation, and then training was a real challenge post-COVID. And likewise, pre-transplant or waitlisted patients, we need to pay attention to their nutritional status, cognitive decline, and their functional status.
Thank you so much for those insights. All right, Megan, would you want to wrap up your program?
I would be happy to. Thank you so much, everyone, for attending tonight's Renal Roundtable program, and to our sponsors and wonderful, talented presenters for their precious time spent speaking on this timely topic. We would like for you to stay connected with us. If tonight was your first experience with the National Kidney Foundation, please reach out to me at megan.schultz, SCHULTZ, @kidney.org to learn more about the work of the National Kidney Foundation. We have also included a link to our participant evaluation form in the chat that you roundtable C that we would greatly appreciate you filling out at your earliest convenience, as we value your feedback in terms of planning future renal roundtables for you all. Thank you so much for joining us tonight, and have a wonderful evening. Happy holidays, everyone.